Because many times there are didactic talks. So you remember something, go home, but in day-to-day practice, we really don't know. And then many times you read the guidelines and say, hey, everybody is trying to do the genetic testing. Where do we stand today? That's the whole idea. Greetings from Siddhivinayak Cancer Hospital. This is another brand new hospital we built about 2 years ago, 350-bedded multi-speciality, and greetings from both the hospitals. So the panel, Dr. Rajiv Sood and Dr. Saurav Kumar couldn't make it today. Dr. Samit Mohanty is uro-oncopathologist. Dr. Shruti Sabnis, well-known uro-oncopathologist from Nadiyad. Dr. Keval Patel is not here, but Dr. Ramesh is around here, and Brishmanu is also here, who has joined at the last minute. So the question is, where do we stand today? So let me take a sort of an audience sort of a call. How many of you are convinced that genetic testing has now become an integral part of the prostate cancer diagnosis, risk assessment, and treatment? Can you have a show of hands? Yeah, even the panel says, but I think both the pathologists are saying no. That's interesting. Now, how many of you order genetic testing? Screening, can you raise your hands? Somebody comes to you and say, I want to get screened for prostate cancer. Do you do genetic testing? Right, 2. Prognosis? You've done a biopsy. You want to tell the patients. Few. Treatment planning? And precision medicine. Right. So on the first slide, everybody feels that genetic testing has come a long way, but in real practice, if you see a show of hands, very few people do in day-to-day practice. So let us start with this. So let us get the basics right. I think there are some postgraduates here also. The genomics is a study of all the genes in the genome and their interaction with the environment. And this is related, but not the same as the genetics. The study of individual genes and inherited traits from the one generation to the next. So when we actually coin the term, basically we should know what's genomics and what's genetics is all about. In terms of genetics in prostate cancer, we have a family predisposition of 5 to 10%. A family history increases the man's risk of prostate cancer by 60%. We all know about it. And in genomics, what we're talking today is how certain the sets of genes in prostate cancer tumor interact and function. Thus, we want to know. And the activity of these genes can then influence the behavior of the tumor, including how rapidly it is likely to grow and spread. And this is what we are trying to understand when we treat the patients with the prostate cancer. We all know almost up to 20% of the prostate cancer, some people quote is about 5 to 10%, 15% are thought to have a genetic component. And this is how the germline mutation talks about. Is about 11.8% of the men with metastatic prostate cancer inherited a germline DNA repair mutation, and about 4.6% of men with a localized disease can have genetic mutation. Now, the era of genetic testing has picked up momentum since 2015, when the Cancer Genomic Atlas Network, almost 19% of the primary tumors mutation of DNA repair genes, and many other organizations actually followed thereafter. And basically, just to make it very simple, to have a basic idea, you have 2 types of testing. One is the germline testing. It tests the genes that link with the hereditary cancer risk, and we use blood, saliva, buccal swab, and screening for a family counseling. So somebody who comes and say, I want to get tested for a prostate cancer risk, I think you do this kind of a test. Well, somatic testing is the test in the mutations of the genes in the cancer cells. So that can be done on the prostate biopsy, your radical prostatectomy specimen, circulating tumor sort of cells, that you can do it. And you can actually have a treatment strategy, meaning risk assessment, what you do, what you should not do, and precision medicine. This is very simple. So in real terms, in genetic testing, genomic testing is basically a molecular signatures, decision making for a treatment, informed targeted therapies. And if you want to sort of know about inherited genes, try and sort of find out the cancer screening, the prevention, and this is 3 different aspects of a genetic testing in a prostate cancer. So these are based on this information. It is very simple, uncomplicated. Right, okay. So this is a 55-year-old gentleman, diabetic and hypertensive. On a routine health checkup, his PSA was 2.5. His father was treated for prostate cancer. He is worried about the risk of prostate cancer in him. Now, Brishmanu, do you think, would you recommend genetic testing for him? I mean, he has come, he is concerned. Would you do a genetic testing? Let us not go about PSA, other things, why did we do it and everything. Genetic testing, would you recommend genetic testing for him? He's worried about it.
If he has a father who has a prostate cancer who has been treated and then he is worried, then it is a case for recommending genetic testing in him.
Okay, the next question is, do you wish to know something more about father's prostate cancer before recommending his genetic screening?
Yes, maybe the grading and staging, what the prostate cancer stage in the father and at what age he was diagnosed.
Exactly. I think the age at which his father had a prostate cancer is extremely important, and this is a very important information. Now, the first degree relative affected, if there is no history of cancer, then probably relative risk is almost nil. But if you have, then relative diagnosed with the prostate cancer less than 65, relative risk is about 6 times, and more than 3 relatives with the prostate cancer, relative risk is 11 times. So I think if father had a disease as an elderly patient, perhaps his worry is unnecessarily. His PS is within normal range, so he probably should not be subjected to a genetic testing. Ultimately, the counseling is important, the stress and anxiety. Like when we order a PSA, when we do an MP-MRI to rule out the prostate cancer, I think you have an anxiety. So you don't want to push him to the anxiety when his father had a disease at the age of 80 years. This is what happened to him. His father was diagnosed as a case of prostate cancer at the age of 80 years. He had a metastatic disease. He had a bilateral orchidectomy. The father survived for 4 years and he died of a natural cause. So this is an entire different biology, the disease what he had. So he is not a candidate for genetic testing to assess for a risk of prostate cancer. Is that clear? Right. Now let us take a case number 2. This is 60-year-old man. His mother, his auntie, his grandmother were treated for a breast cancer. Father healthy. He was screened for prostate cancer negative. He read about BRCA genes since he was involved in their care. And now, should he be screened for a prostate cancer? Dr. Shruti, should he be screened for a prostate cancer?
I think so.
You think so? Any
Yes.
justification for this?
Because even though his father was healthy, but he
Okay.
can still have a risk of hereditary cancer since the maternal side has a history.
Okay, fine. The genes and their mutations. So we all heard about BRCA1, BRCA2, and the list is getting longer and longer. So if you look at the panel, what actually are done, you have a risk, on this sort of a gene, what you have a BRCA1, BRCA2, prostate cancer risk is about 20%, 20%. And if you look at the HOXB3, is almost like 60%. So these are the panel of sort of genes what we are actually sort of studying and trying to find out what is the prostate cancer risk. It's just not ordering the test as such, but I think we should also have an information what is the percentage of risk of prostate cancer in these kind of patients as such. And to elaborate it more, if you have BRCA1, BRCA2, I think prostate cancer risk is fairly high. Risk from other cancers is also high. And you see the HOX13 and sort of other sort of a gene panel, what you see, you have decreasing, but there is a limited sort of a data on these kind of panel as such. And also sort of this can be used subsequently for a therapy we will discuss in a short period of time. And just to reinforce what I was trying to say, that if you have a family history of breast cancer, you worried about BRCA genes, I think you can order this test and say this is probably a risk of inherited the prostate cancer itself. Now, Sambit, having ordered this test, you give us a report, this is what it is. Now, as a clinician, am I qualified to counsel the patient to reassure him that you have a prostate cancer risk or you don't have a prostate cancer risk?
No, I mean, none of us is qualified to counsel the patient. We need to have a medical geneticist intervening in pre-test as post-test counseling for both.
So it's important for the audience also to understand, you have a test doesn't mean that you have to order it. There may be people who are coming with anxiety and saying that I want to get screened. Yes, fine. You want to get screened for a genetic testing. So we discuss when to order. We discuss sort of how to order. And also it's important, it's like you have a MDT meeting, you have a radiation oncologist, medical oncologist, you have pathologist, radiologist in that group. I think when you want to do genetic testing, you should have a department of medical genetics who's qualified to counsel these patients even before the testing. It has a stigma, it has a sort of a stress, it has an anxiety, it has long-term implications. So you may order the test with the consultation of your medical genetics department as well as the sort of pathology and sort of people who do the gene panel, and then subsequently take them for a counseling is extremely important. Now, genetic counseling is must, it's a different specialty itself. Now, Ramesh, do you actually sort of order genetic testing? Both Ramesh and Dr. Sood, different areas of practices here in the metros. Do you order genetic testing, and what kind of panel you order?
Yeah, in Bangalore, there are a couple of labs which do these multi-gene testing, and we have started doing this. It's not very common, only in these high-risk population. We recommend, but not everybody gets it done. It's not done on our hospital. We refer it outside to a lab who do these multi-gene testing.
Okay, Dr. Raju Sood?
Yeah, I'm now in Punjab, and we have 3 cancer centers attached, and we are recommending, especially it is done. It is actually done in the trial settings there. And as a routine, these are now, of course, the cost has come down there, but still it is done, but not that frequently.
So what point actually you advise it, Rajiv? Suppose you have a guy who you have diagnosed as a case of prostate cancer, done a biopsy, done MRI, PSMA PET scan, whatever staging you want to treat the patient. At this point you do genetic testing? Or after finishing your primary treatment, you do the genetic testing?
No, actually, it all depends whether this is organ confined, gleason is more than 7, or the family history is there. Mostly, if it is confined, even high grade, we don't go for this. But if we see that the family members are involved, or these breast cancer, ovarian cancer, melanoma, these conditions are there, or 2 or more members or generation are involved, then we suggest that it is good if you can get it done.
So you do it for the patients to know the risk assessment, the future chance of failure or additional therapy. Also, if there is a strong family history of other malignancies itself. That's fair and square. Now, germline testing, you can have different sort of panels. You can have a small panel of 6 genes, 10 to 15 genes, 80 genes. There are people who have expanded sort of ones. And if you talk to Sambit, I think he will make you crazy, and you give you a lot of information and say, do this. I'm just trying to just give an example. When you talk to the pathologist and say, do what it is. So you really get confused about it. And you can do a skin biopsy, cultured fibroblast in bone marrow transplant stem cells, and buccal mucosa, so many other things you can do. But typical panel, I think minimum 9 to 10 sort of, the genes what you study is important, because it not only tells you the risk of prostate cancer, but also would tell you what kind of therapy you should do. Now, how to interpret? Sambit, how do you interpret, and what are its implications? Interpretation.
So typically, we have 2 kind of testing, germline or somatic. So whenever we have a metastatic setting, we basically we start with a somatic testing from the tumor tissue, whatever.
No, let's talk about the
germline. So germline, we basically cater to those 10 genes you showed. Those are the genes of DNA repair pathway, and they're the major players in in prostate cancer. So we divide them into pathogenic, non-pathogenic, and VUS, and you look for what is the frequency of those mutations. And depending on the frequency, we decide if it goes beyond 50%, that is probably it is inherited. If it is less than 50%, it's probably by a chance.
So the second guy, which in the second case which I showed, he had a family history of breast cancers. He goes through this sort of germline testing, and the report comes as non-pathogenic. So he is assured that he is not going to get a prostate cancer. Is that right?
Not really. I mean, it is non-pathogenic today, maybe three years down the road.
As of today.
He has no risk.
Oh, right.
But later on.
Okay. But if he says he has a variant of uncertain significance, does it mean that he has to have a repeat testing again?
No, we do not need a repeat testing, but we have to see what is the percentage of cells in that particular sample has VUS. If it is 5% or less than 10%, he can be fairly assured of that. Nothing is probably going to happen, but he should be on a red flag kind of setting. If it is good beyond 10%, then definitely more work has to be done.
Sure. So this is basically, I think in the conclusion wise, you do order the test, the report comes as pathogenic, likely pathogenic. It can be used for screening, counseling, treatment, and prognosis. Because again, you have to take the help of the Department of Medical Genetics department. Non-pathogenic, no further action. I slightly disagree with what he says that you have to repeat it after some time is not eliminated. But as of today, I think is no. We don't really have to push him to dungeon.
I mean, we do not have to repeat it actually,
Yes.
but we have to keep
Yes.
the person on follow-up
Yes.
because I have cases of SDH-A deficient RCC
Yes.
in 2017.
Yes.
It was non-pathogenic.
Yeah.
In
We're talking
2022
about the prostate
so,
cancer.
whatever
Yeah.
we think, I mean, the genomic library is changing.
Sure.
So 5 years down the road, we do not
Maybe.
know
So
what
as
is
of
happening.
today, he shouldn't be worried about it. But you cannot recommend any treatment if the report comes up US because when we order the test, we know to what its implication is like. Because you can't go back and forward to the medical genetics guys and say, we ordered this, what is the report, what do we say? Because you shouldn't be as confused as the patient and the family itself.
Right.
So in terms of screening, BRCA2 carriers, there is a high incidence, a younger age of diagnosis with a clinical significant disease, 77% versus 40%. That's an impact study. And all the NCCN guidelines now suggest that BRCA1, BRCA2 carrier screening for the prostate cancer should start from the age of 40 years. If somebody comes, it's the BRCA1, BRCA2 carriers, then they should have screening, meaning for the prostate cancer, not the genes, but you can do your PSA, you can do your MPMR and everything. So this is what the implication is all about. A 40-year-old guy and says, I want to test for the prostate cancer, BRCA1, BRCA2 positive, then you start your clinical screening and imaging screening for a prostate cancer. And if you have HOXB13 or DNA mismatch repair, I think there are still sort of an evolving data. You agree, Shruti, on that? Yes. Yeah. Now, these are a lot of tests which are available here in the market, and these are sort of, the American cost itself. And as Dr. Ramesh has said, you can get an online. You just go on online, like on Amazon, and you just try and find out. And it's very simple, they make it. Brushmanu, do you have patients in Delhi? Do they actually sort of go online and keep on ordering it?
It's not about online, but I would like to just take that question Dr. Shuhud was telling.
Yes.
In our center, actually all patients, those who are diagnosed with metastatic prostate cancers, the medical oncologists, they are routinely now doing genetic testing. Though it is recommended in all high risk, localized and in locally advanced prostate cancer, we do not do it.
Okay.
But for all metastatic prostate cancer, the medical oncologists are routinely doing it.
Yeah.
That panel of 15 genes,
Okay.
and it's easily available outside in
Sure.
Delhi.
Sure.
Maybe it's not very high, costly.
Sure. Because
The test.
over-enthusiastic patients, moment you diagnose somebody with prostate cancer, they will screen you, they will find out what you're doing, what your results are like, they will look at the website, and also they will keep on coming whether we can order this test because other family members are like this. And as Dr. Ramesh has said, you can get to the companies, and these are the different costs. It's something like 15,000. And that's a different entirely discussion. We had discussion in MDT. And how much we are going to go further to add the cost of the treatment before actually go? Because previously we were doing prostate biopsy, CT bone scans. Now we are doing an MP-MRI, we are doing PSMA PET scan, we are doing the biopsies. Now we are going to do a gene testing, and then we are going to start for chemotherapy. So it's going to be an expensive affair in terms of metastatic disease.
Just a minute, Makran. Before we go into the treatment part, as a part of screening and counseling, the declaration for insurance companies and for employment,
Yeah.
I think you need to...
Sure. So somatic testing, like we talked about screening. We talked about whether they have a risk of prostate cancer. So the patient had a prostate biopsy, patient had a radical prostatectomy, or people are talking about circulating tumor cells, Now these are the alterations, they are not inheritable, what we're talking about. And the next generation sequencing panels are HRR, microsatellite instability, AR amplification, PTEN deletion. This is what we are testing on a somatic testing. So let us look at this guy. He's a 70-year-old guy. He has no comorbidities at all. His PSA was 7 nanogram per ml. His MP-MRI showed Pyrades 3 lesion in the peripheral zone on the right side. His 12-core biopsy was done, left 6 cores, all negative. The right 1 core positive, 3 plus 4, 7, grade group 2, less than 10% core positive. Now MP-MRI organ confined disease, he has no nodes, no metastasis. Now the treatment options. Now we discuss whether he can radical prostatectomy, radiotherapy, active surveillance, focal therapy. His son who lives in Australia wanted him to have a Decipher test. Dr. Sood, do you think, we should be doing it, or we agree to get this guy to do a Decipher test?
I think this is organ confined disease only a very, one core is only positive.
Okay.
So we should go for radical prostatectomy.
That's fine,
upfront.
but there are the different options.
Yeah.
And he says, doctor, you say, almost like 11 cores were negative, 1 is positive, it's a grade group 2. am I, a candidate really for a surgery or radiotherapy? Why I cannot have an active surveillance? So he wants to know. So Ramesh, do you say that,
We
I
don't
would have
do
it-
this test in Bangalore, but I think if you go by current guidelines, any patient who is on this intermediate risk and is going to go on active surveillance needs to get a genetic testing.
Both the pathology teams, do you concur with this opinion?
I think, because the patient has a 3+4, there's a component of 4. So even if we have a Decipher test and Decipher shows a low score, still I would not recommend.
Brishbanu?
So I think this patient has the intermediate favorable risk with the PSA is less than 10. It's 3+4, only one core positive. He actually very well is a candidate for both either a active surveillance or surgery depending upon whatever the patient after the counseling. Decipher test I don't think is likely to change much in his management.
So basically, just to tell you about, Decipher test looks almost activity of almost 22 genes in the prostate cancer. This was taken up, Nature's sort of a journal. And this is how we interpret, like we talked about the gene panels and how we interpret, the different germline testing. So when you get Decipher, they will give you it's a low, intermediate and high, right? So low, 0 to sort of 0.4, low risk of metastasis and the death from the prostate cancer. And this is about a high risk of metastasis from the death and prostate cancer. So we're talking about death from the metastasis. We're not talking about whether he will have sort of disease-free, what kind of treatment it would have. His score was 0.2 and he was a very intelligent guy working in atomic energy. He opted for active surveillance. And now he's doing well for last 4 years. His PSA is still around 7. His DR is completely unchanged. And he is still going through the active surveillance protocol itself. Now this case is about 65-year-old guy who's diabetic, bladder outflow obstruction-like symptoms. The DRE showed enlarged prostate. PSA was about 9. MP-MRI showed pyrites 4 left lobe. And he had a targeted biopsy. The targeted biopsy showed adenocarcinoma prostate 4+4, grade group 4. Intraductal carcinoma about 10%. Cribriform pattern also seen. And a PSMA PET scan was organ confined disease CT2 or what we call as a molecular imaging T2N0M0. Dr. Shruti, do you think he should get a somatic testing for aggressiveness of the disease and prognosis and a treatment? The guy who had intraductal carcinoma and a cribriform pattern.
Yeah, so ISUP recommendations do suggest that even if it is an organ confined disease but shows grade group more than 4, or presence of intraductal, they can go for somatic HRR, but
Right.
I don't think that is followed in India.
Right. Okay. Fine. Somatic testing, again, different kind of different testings are available. It tells you about, you do a foundation, 14 HRR pathways and 14 HRR pathways. You can do different kind of testing as such. It's very interesting for all of you because we are all confused. But when it comes to us, as a patient, suppose any of you unfortunately diagnosed as a prostate cancer, what are we going to do? And this is a wonderful article which I came across in a precision oncology. And he was a guy, who actually how I faced my prostate cancer. He's a molecular biologist and his perspective itself. And he thought, I think this testing, somatic testing, genetic testing actually helped him to actually plan the treatment. And what he said was very right in his article. You should all read this article and precision oncology paper. It's more important to know what sort of person has a disease than to know what sort of a disease the person has. And I see it's very, very valid. And this report documents his experience, how his aggressive prostate cancer was treated. It was really an eye-opener. I think probably coming towards the end, this is a 78-year-old guy, again, more than 100 PSA, metastatic disease, pelvic lymph nodes. Now the question is, Brishbanu, does he need genetic testing?
Yes, he needs.
Yes.
It may not alter your treatment upfront, but he needs
Yes,
a genetic
yes,
testing at the
yes.
present.
So I think it's important, metastatic disease, and if somebody who has that kind of disease, and that's why your medical oncologist actually advises it, because you know whether he is good for PARP inhibitors or something like immunotherapy. It can be given with abiraterone, it can be with immune checkpoint inhibitors, and what you do is do this run panel, and if they are positive for MLH1, MSH2, then perhaps these candidates would for immunotherapy. Otherwise, the rest of them can be treated with platinum-based therapy. So in last few minutes, I'll just tell you the guidelines, how the guidelines are now saying, because we made it amply clear with simple cases as such. So when you do genetic testing, metastatic prostate cancer, the last case what we talked about, High risk, very high risk localized prostate cancer. Intraductal cribriform histology, I think you should do screening. Jewish ancestry, I think doesn't apply to us. Known related cancer risk mutation in the family, and 3 generations of maternal or paternal family cancer related to history, at least BRCA1 and BRCA2 assessment should be done as such. And these are the criteria which are there in the text, in the NCCN guidelines. Now putting it to the germline testing, very low risk, if you have a risk stratification according to the Gleason score and the PSA, only in patients with a family history and intraductal histology. Family history, intraductal histology, but if you have a high risk and very high risk, I think you should recommend genetic testing. And these are the few sort of important things, and the role of genetic counsel is extremely important because it has psychological, financial and therapeutic implications. We in Australia and Asia, we have APACC group, and recently we met in Singapore, and also we looked into these sort of guidelines, and our recommendations were same as what we discussed: young, high-risk patients, screening, strong family history, and we are excited with therapeutic implications, though not routinely practiced, but the cost is an entirely issue. So in conclusion, I think we made it amply clear, go through this pathway, do only in sort of select group of patients. Is recommended in all the guidelines, and you require very, very important medical genetics department. Now let me ask at the end, now are you convinced that genetic testing has now become integral part of the diagnosis and treatment, audience? Yes. And how many of you order now for a screening, prognosis, treatment planning and precision? The same question I asked. Are you convinced that we should do the test? Sorry? Yes. Thank you very much. Thank you. And I think the future is going to be the AI in prostate cancer.
Can I have a question, please?
Yeah.
Just one quick question.
Yeah.
Excellent presentation, Dr. Kochigar. Kudos to you. So, after all this genetic counseling and genetic testing, are we there yet to offer prophylactic prostatectomy?
I think it's a big question. I don't think if you have, that's my second talk and sort of discussion what you're going to have. One step ahead, whether we should be doing even sort of surgery without any evidence of histological proof. Though both the questions are not similar, but I think if you have a risk, prophylactic prostatectomy, I don't think it has come in a way at all. I don't think anybody would recommend. Is a complicated operation, it's not a simple operation. It's not something, people are talking about prophylactic mastectomy. Now, people are doing thyroid surgeries, people are doing sort of colectomies, people are doing prophylactic mastectomies, but I don't think we have reached a stage like Angelina Jolie's story, you do a prophylactic prostatectomy, because the operation itself is comorbid, impotence, incontinence, and so many other complications, unnecessary.
So, may I ask one question? So since we have not reached this stage that we are able to recommend any sort of therapy when in a patient who is genetic mutation positive versus not positive. So with respect to the screening and family history, are we benefiting those patients or doing more aggressive screening in those patients who are positive versus non-positive, meaning thereby a patient who has a family history and has a genetic mutation positive versus one who has a family history but is a genetic mutation negative? So if there is no change in terms of the management or screening,
I think there is a point what we made here.
How we get wiser in terms of...
Yeah, we are wiser. So first thing, it has implications. It's like doing a PSA test. Unless you inform consent, you don't do a PSA test. Like an HIV test, you don't do sort of, test unless it has sort of, it has implications, psychological implications. But if you have patients who are genetic test, germline test comes positive for BRCA1 and BRCA2 in the family history, you start screening these patients for a prostate cancer from the age of 40. That's the point we made. But if it is negative, you really don't have to. Whether you act later or not, that is a different story. But it's a complex issue.
Thank you, sir. Thank you very much, sir. Thank you, Kochigar, sir, and esteemed panelist, I would say, and they did a fantastic job. So we move on to the next session, which is the star talk by none other than Dr. Mihir Desai, and we saw him yesterday operating radical prostate and partial nephrectomy. What we could not see was radical cystectomy. So this star talk would be on radical cystectomy with intracorporeal diversions. And I would invite Dr. Amit Ghosh, the chairman of Uro-Oncology section, Dr. Shrenik Shah, the organizing secretary of this gala event, and myself. Thank you.
Dr. Shrenik?
Yeah. Can you
connected to the theatre. Okay, for this 2 days conference, we are absolutely thankful for all live surgeries. This is our department, Department of Urology Civil Hospital. These are, then I think there are also from the HCG, MPUH and Preeti Hospital. So we are thankful all the places for all kind of live transmissions. Yeah, thank you very much. And I think one of the most important person who I am missing is all this good quality or hello is not happening. All credit to Anand.
Before we take permission from Mihir, just to give announcement, can you put it on the screen, please? Ladies and gentlemen, thank you very much for making this second conference a great success. With the enthusiasm that has been generated in the young, we are treating the older generation for urology, but we've actually hit a huge crowd in India in the young urology faculty who has made this program a big success. And so much of enthusiasm that we actually had to finalize and open the payment gate for the next conference in Hyderabad, probably in the month of May. We will let you know. But our appeal, before you disappear into your jobs from tomorrow, please, if you can register, it's me, the chairman and the secretary has already registered. The payment gateway is open. We have kept it at an initial cost of 5,000 plus GST and 3,000 plus GST for the PG trainees. And therefore, we would be grateful if you take a little moment to open your telephone and link it with the payment gateway and get your payment and register. That will boost up the morale of the organizers. Thank you very much. Please, over to you, Mary.